All right, you guys, we are going to get started on this dermal filler safety webinar, and I just want to thank you for taking time out of your busy day to join me. I think this is such an important topic, which is why it was overwhelmingly popular. So we've had quite a few people sign up to join us. And on that note, if you have any questions while we go along, please save them for later. If you have a piece of paper and a pen handy, then write those down. And whether you're watching on Instagram or on the webinar, then we can certainly talk and have some dialogue. I want to make sure and have time at the end for that, especially because some personal stories would be really helpful to share, and I'll share some of my personal stories as well, and especially when it comes to talking about dermal filler safety types of things. So we're not going to talk a lot about product today, if at all. Just assume when I'm referring to dermal filler that I'm talking about HA, just your basic hyaluronic acid filler, because even though we know that there's variances with all kinds of fillers, really the majority of our vascular occlusion episodes, which is the thing that we're most concerned about, that's happening with our HA fillers. Whether they're this filler or that filler is really inconsequential. The techniques and the safety measures that we're going to talk about today are universal. So it's regardless of what kind of filler that you're using. But if you have specific questions about fillers, then we can discuss that at the end. And some of you have not taken courses with us here at Pacific Northwest Aesthetics Academy, but we are product neutral and we love all the products on the market. We are not paid by any pharmaceutical companies to promote their product or to train on their product. So that's something that we feel very strongly about. We also have position statements on the dermal filler no-fly zones. And so those are things that we feel very, very, very strongly about. So I don't intend for this webinar to be a infomercial. So if you're not aware of who we are and what we do, then head on over to our website. It's pnwaestheticsacademy.com. And we do trainings. We do lots of different trainings. And if you haven't met us in person yet, we'd love to meet you sometime. So just let's get right into it. I have been in this aesthetics industry for 8 years. I took my initial training in 2012, and at that time, there was no mention of vascular occlusion, any dermal filler episodes, what those look like, what the treatment was for that. I've got a pretty good memory, especially when it comes to classes that I feel very, very passionately about, and I love my training, but I left there not knowing that I didn't know a whole lot about safety when it came to dermal filler, and I made a lot of mistakes, and I am literally shocked that I didn't hurt somebody in those first few years. And another part of what we do here is we support and we mentor. And it's really been just so fulfilling for me because I have students who have called me with these vascular occlusion or what they suspect is vascular occlusion. And I appreciate that. And I want them to call me, and 100% of the time, regardless of whether they're certain it's a vascular occlusion episode, they're treating it as if it is. So they're doing all the right steps, which it makes me feel even better and professionally fulfilled. It means that I'm teaching them the things that they need to know. And it's what I didn't have initially. So if you want to reach out to me about anything today, I'm very approachable and easily accessible on Facebook, Instagram. My email address is wendy@pnwaesthetics.com, and it's AESTHETICS.com. And I would love to be of any assistance because our primary goal as a community is to do no harm. So if I can help in any way, I want to do that. Also, if you are an aesthetic provider already and in your office you don't have a vascular occlusion protocol, please reach out to me and let me know, because I can email you one that is pages long with an accompanying research article all about vascular occlusion and how to treat it. So those are things that, I mean, you have to have that in your office, and you also have to have the medication to treat a vascular occlusion episode should it occur. So we have people who are watching us today who have not done, excuse me, any aesthetic training, who've done some, who have been practicing for a while. So it really runs the gamut. I think we might even have people on here, consumers, which I also really welcome, because our consumers are becoming more savvy, which means they're asking the right questions. I had a patient last month who I was doing her under eye area. So I was doing tear trough on her. And when she called me, she said, I know there's a chance I'm going to go blind. And so I just want to make sure that you're safe and that I'm not going to go blind. And I was like, you're not going to go blind. Like, I'm just like, she had done like so much research. And so when she came in, I took a long time to consult with her and explain all the ins and outs and how we were going to ensure that this procedure was very safe. And once she felt confident and we started moving on, and I started treating one eye, and I was pausing and I was going to move on to the next eye, or I was reassessing, she's like, okay, so if I was going to go blind, would it happen now? Or was it going to happen later? And she's like, am I totally in the safe zone now? Are we good? And I was like, we got to do the other eye still, but yeah, I mean, we're doing good. So your consumers, your patients are more savvy now, which I think is fabulous. It just lends us to having our patients seeking safe injectors, and not just going to somebody who's buying filler off the internet from Europe and opening up a spot in their house, some unlicensed provider. So our consumers are definitely asking questions about filler and safety things. So you can find lots more information about me on all the social media, and would love to chat with you in person if you need, or by email. So hopefully, if you have attended our classes before, some of this information will be redundant, but you have heard us say over the last 6 months that we have changed some of the curriculum. So that's hopefully will be new and something that you can implement to be a safer injector. So the other things that are going to be really helpful are additional resources to you. So always knowing that it always comes back to anatomy. Dr. Chris Surek, who is one of the authors of this facial volumization book, that every injector should have this. If you don't, go on to Amazon and order it today. It's called Facial Volumization, an Anatomic Approach. So it's full of really great illustrations of the anatomy, and it's got a lot of links that will take you to even more beneficial resources on the internet. In addition to that, Dr. Surek does a cadaver lab. That's a very private cadaver lab training in Kansas City, and it's I don't know what the max enrollment is, but it's a very small group, and you do the injections into the cadaver, and then you actually dissect the cadaver to see where your filler went. It sounds amazing. I actually was fortunate enough to get into the June class, June 22nd. That you can find on injectionanatomy.org. If you want more information about that, go to injectionanatomy.org. If you're not already following Dr. Chris Surek, S-U-R-E-K, on Instagram, follow him. He's got a ton of information. The other thing that is super helpful when it comes to anatomy, Dr. Surek has also trademarked the term, the fear of injection is the fear of anatomy, meaning, if you're that fearful, I mean, it's pretty easy to interpret that. So it all goes back to knowing those underlying structures. And if you are able to, every time you stick a needle in someone's face, if you're able to visualize what's going on underneath there, then you're going to be a safer injector. And there's not a single time that I poke somebody in the face. I mean, every time I poke somebody in the face with a needle, I'm always thinking about what's happening under the skin. Super, super important to be thinking that. It's those injectors who are very brazen and haphazard and who just go for it without any thought for patient safety or anatomical structures. Those are the injectors that get into trouble. So think about it every single time. And I really disagree with the statement, it's not a matter of if, it's when it's going to happen, which is, I disagree with it because I've been doing this for 8 years, and knock on every piece of wood I have here, I haven't had anything happen to me with my dermal filler, a vascular occlusion episode. And I had and of course, the more volume you do, if you're doing hundreds of dermal filler treatments a week, the chances go up for sure that you might have a vascular occlusion. However, if you're being the safest possible injector you can be, then you shouldn't have any issues. And I had a conversation years ago with a medical liaison from one of the pharmaceutical companies, and they were asking me about my percentage of vascular occlusions and if it's happened to me in the past, and I said no. And they said, well, is that because you're just an amazing injector or are you lucky? And I said, well, it's neither of those things. It's because I'm very safe. I treat my patients very conservatively, and I don't think it really has any element of luck. But also, kind of speaking to that, even knowing your anatomy, like 100%, all the ins and outs, everybody's got variances. So humans are not symmetrical creatures. We are not identical creatures. So knowing where those structures are and how to avoid them and how to inject safely is important, but also realizing that there's a lot of variances in human anatomy as well. So those are all just kind of things for you to think about. Other resources that are really super helpful on the whole cadaver note are the conferences that we have available as injectors. So the one that's coming up most soonest is the Los Angeles MCAs. That's at the end of March, and I think that they have 2 cadaver labs. And I attended a cadaver lab last year at the Scale conference in Nashville. That was amazing, and I'd been told, like, oh my gosh, it's so helpful, it's so helpful, it's so helpful. And I really didn't expect it to be that mind-blowing, and it really was. I felt much more secure as an injector after I had actually seen the anatomy in the face at that depth from what we do. So the Scale conferences in Nashville at the end of July. I already told you about the LA MCAs. ISPAN, also the International Society of Plastic Surgical and Aesthetic Nurses Conference, is very good, and that's in early October in San Mateo, and there's a cadaver lab with that conference. So I encourage you to experience that just as soon as you can, because it just really just brings the whole concept of knowing your anatomy home. Another really good resource is an app on your phone. It's called Essential Anatomy 5, and it is $14.99, I think, to download. It's a one-time fee, and then you can use that to look at the anatomical structures. You can also use that to show to your patients, to let them know, like, why you're not going to do a liquid rhinoplasty on this patient. And you can show them in this 3-dimensional CGI view of all the structures that are going on there. So it really has been super helpful for me to show my patients, like, no, I'm not going to put filler in your glabella, this is why. So that's another really, really good resource to use, Essential Anatomy 5. Another really good resource, if you're not already following Julie Bass Kaplan, she's under the IG tag Juvederm Julie, and Julie is an amazing instructor, and she speaks frequently about her experience with vascular occlusion. And it happened years ago, but she looks amazing. She doesn't have any outward sequelae from the experience. It took quite a while for her to get over that vascular occlusion episode, and her story is very informative. It's something that every injector should read and should know about. Also on Julie's Instagram page, she has got some really great videos and pictures of what a dusky appearance from a vascular occlusion episode looks like. So, and that's the number one question when we're teaching our basic injectors during dermal filler day is, well, how do we know? Like, what does it look like? Is it like a bruise? And we'll talk about that a little bit more later on, but Julie has got some really great pictures of what vascular occlusion episodes could look like. So we'll talk about the symptoms of that later in a little bit. So of course, everybody out there, we all know about aspiration now. It's so interesting because 8 years ago, we didn't talk about it at all. Nobody aspirated. And now the pendulum has swung back into aspiration. Of course, we're teaching that during our basic injectable class. We're aspirating, aspirating, aspirating. Even when we're on the periosteum, we're going to aspirate. Even when we're using a cannula, we're going to aspirate. And why not? It is just one of your safety measures when you're doing dermal filler injections. How long should you aspirate? Everybody's kind of got a different opinion on that. And how I answer that is aspirate until you feel comfortable that you're not in a vessel. So pulling back that plunger, seeing a really good bubble of air come up, maybe waiting another 10 seconds and then moving on. If you do see a stream of blood, if you get a flash of blood back into the hub of your needle, you're going to stop and you're going to move on to somewhere else. You're going to put pressure on that area. You're going to move on to somewhere else. And it's not a horrifying thing. You don't need to send your patient home. You're just going to like keep that in the back of your mind. Maybe this person is just a super big bleeder and you just sheared through a capillary bed and now you're getting some extracellular blood. Or maybe you're in the facial artery. You don't know. So just stop and move on to something else. So why not aspirate? But also don't think that because you didn't get a flashback that you're 100% safe, because you're not. You're trying to pull some blood out of a vessel through a 27 gauge, typically needle, into a 1 cc syringe filled with a hyaluronic acid gel. So that is difficult. I remember back in the ER trying to draw ABGs and seeing the radial artery and still not being able to hit it. You know, it's not easy to get that, but it happens and it is rare, but thank goodness we're hearing about it a lot and that we're being educated about it, because it just, I'm still just astounded that I didn't hurt anybody in the first few years that I was doing dermal filler treatments. And knowing about hyaluronics and making sure you have hyaluronidase, whether it's Hyaluronics, Vitrace, whatever brand of hyaluronidase you use, having some in your office. And typical, mid-size office, at least 8 vials of it is a good rule of thumb to have there. So the other thing I want to talk about is also cannulas. So the evolution of cannulas has come a very long way as well. So whenever you have the opportunity, use a cannula. They're great, and they really are going to elevate your practice and make you a safer injector. And we'll talk about specific areas to use the cannulas and how you would choose the size, which has also gotten a lot easier. I mean, there's many different sizes of cannulas on the market, but when you choose a cannula, remember that the smaller your diameter gets, the smaller your gauge, makes it much more like a needle. So if I'm using a 27 or a 30 gauge cannula, that's very similar. The bluntness is not so blunt. It becomes pretty sharp when you're using that gauge of a cannula. So my advice, 25s minimum, 22s even better. I love 22 gauge cannulas. It's what I primarily use 100% of the time in every area. It is also, if you have some 22 gauge cannulas, and it's kind of fun to, like if you use the back of your hand, put a cannula, put the 22, not like you doing it to yourself, but to somebody else, you can see the vessels on the back of your hand really well, and you'll be able to see that cannula push that vein away. I have seen it when I was doing a temporal filler, and using a 22, and the very superficial vessels up there, I could see the cannula just move those out of the way. Super safe with a 22 gauge cannula, and using all those other safety measures that we have in place. Also on the cannula note, the length of the cannula is also variable, and you have to remember that the longer your cannula, the more extrusion force that you need to get that HA filler through the cannula. So consider that as well. We typically like a low extrusion force because the harder you push, the more likely you are to create that back pressure if you happen to be in a vessel and cause something very serious like a backflow into the retinal artery, thereby causing a secondary blindness episode. So nobody wants that. So remember, the extrusion force can really affect what you're doing as well from a safety standpoint. So let's talk about the areas of the face that we typically inject and traditionally have always been what patients come to see us for. 8 years ago, we didn't do cheeks. And so that's been a beautiful evolution of our industry. With all the areas, typically aside from lips, if we address cheeks first, that patient will see results in all those other areas. So if we're addressing the cheeks, lateral and medial cheek, you're going to see a nice softening of the nasolabial folds. This mounding will be less, your marionette region, your under eye region. So anytime a patient comes to you, I encourage you just to think about cheeks first, because the area of the cheek, you're going to do periosteal boluses, so it's going to be usually the first method that you go with. So in the cheeks, you're going to be laying down right on the zygoma here, sometimes the periorbital rim, and by strengthening this area here, which is where we typically lose our bone density and our fat pads right up there, as we age, everything just falls. You can really enhance everything else. And it's super, super safe. You're gonna go right on the bone. So, and why is it safe? Because there's not much stuff there. There's not a whole lot of vascular there. This is another really good learning reference board that we like a lot. We have this for sale on our website, but you can also get it through brevoboards.com. So I like this to show to my patients, and of course we use these during our trainings. brevoboards.com, really good stuff. And so there's not a whole lot of vascular structures happening there that you're going to worry about. The other thing also in that area is you're doing periosteal boluses. So you're going right on the bone. And when you do that, and when I'm instructing brand new providers, the first time they do that, you tap on the bone, and there's no other time in my acute care history that I wanted to hit the bone. I didn't do bone biopsies in the emergency department. So that was a really unnerving sensation to hit the bone and to know that I needed to stay on the bone. So it's kind of intuitive or instincts to hit the bone and go, oh, and come back a little bit, but you need to stay on the bone. If you come back a little bit, you may have just pulled that tip of the needle back into a vessel. Yes, of course, you're going to aspirate still, but remember, you won't always get a flashback, even if you're in a vessel. So on the bone, stay on the bone, and then you're going to do boluses in the cheek area. However, I have seen a video recently of the cheek boluses, and somebody wanted more of the Gigi Hadid, or I had a patient who asked me for Lady Gaga cheekbones. And so that's more that really strong lateral cheekbone. And in the video, the provider was doing periosteal boluses, and like probably 3 rows of 4 periosteal boluses closely together, which is great, but I find that I can get that same effect and actually a more beautiful, smoother effect by using a cannula. And it's going to be deep, and we can come here and go this direction and fan this way. And you could do your insertion spot here, fan laterally with your 22 gauge cannula, and you could do a little medial. So cannulas also give you the benefit of using one insertion spot and being able to have multiple areas. Cannulas are amazing and safe. So remember that you're going to follow all those same safety things while you're doing that. You're going to go slow. You're going to put down small amounts of product. You're going to aspirate. You're going to always have that cannula / needle in a linear motion. Retrograde, even when you're using a cannula, you're never pushing the product in as you're going forward. That makes absolutely no sense from a physiological or from an aesthetically pleasing standpoint. You're not pushing the product in as you're going forward. You're laying the product in as you're coming back out, and always keeping the tip of your cannula in motion is key to being super, super safe. So those are kind of different ways to approach the cheek. They are pretty standard and have been since the inception. Cheek boluses anywhere are pretty easy and safe, and we are definitely we've added that to the curriculum of our basic injectable course. So our dermal filler students are learning that now. Which is where the difference has come in our curriculum, and from hopefully more of the evolution that we see is when we talk about the nasolabial folds. So the nasolabial folds account for 33% of the reported vascular occlusion episodes. So what does that mean here? Well, first of all, it makes complete sense, because if you look at your anatomy board, how the facial artery starts coming up just right along the nasolabial fold right there. It is kind of curvy. It's like this, and it also is deep in that area, but then it goes up and it gets a little bit more superficial right here at the base of the ala. So you could cannulate that and put some product in there, totally conceivable. Or if too much product is placed and the patient has a lot of edema, then they could present with a occlusion episode 24 to 48 hours after the treatment, and we'll talk about ways to mitigate that in a little bit. But how are we going to treat the nasolabial fold? Like, everybody comes in and they're like, these are so heavy, I just don't like these. You're going to look at the cheeks. That's what you're going to address first. You're going to look at the cheeks, and there are plenty of fillers on the market now where you can do cheeks. And then if you need to, you can come back after that and you can add more hair. Now, if somebody's got cheeks out to here, you're not going to do that. You're going to come back to the nasolabial folds if that's what really bothers them. It always goes back to your good assessment, your great consultation techniques. So what are we going to do here? You're going to think about lifting this area right here in this little triangle, which typically we have done fanning in that area with a needle. Just don't do that anymore. Just stop doing that. Go straight down. You're going to do a periosteal bolus straight in at a 90-degree angle with your 27 gauge 1/4 inch needle. You want to hit the piriform. So the piriform is this bone right here, right at the base of the ala. So you're going to go down to bone, you're going to stay on the bone, and you're going to aspirate. And once you are confident that you are in a very safe location, then you're going to do a periosteal bolus of 0.1 to 0.3. I'd heard a story of someone doing 0.5, which seems like a lot, but the basic thought process is you're just going to lift that tissue right there. So watch what's happening and lift that tissue in that area. It's amazing. The first time I saw it done and the first time I did it, I was like, that's kind of mind-blowing. Whereas before I was like, oh, fan, sometimes it's lumpy, sometimes it doesn't look right. Periosteal bolus lifts it right up. So beautiful. So then what if they still have lines down here, maybe some deeper etched in lines that you want to fill in that area? Break out your cannula. It makes sense from a safety standpoint and from just a puncturing your skin standpoint, because yeah, I could pull out a 27 gauge 1 1/4 inch needle, or I could use my 27 gauge 1/4 inch needle and lay down thread of HA filler, or I could break out my cannula and do just one nice linear thread with my 22 gauge 1.5 inch cannula. So think about cannulas always. Before you know it, you will be so comfortable with the cannulas, that's all you use. I was doing a training last week with a dermatologist in Seattle, and she's been in this industry for like twice as long as I have, about 14-ish years. And I was asking about her use of cannulas, and she said almost 100% of the time cannulas now. she said, you know, if I like stick a needle in someone's face, I'm kind of like cringing. Like, you know, me too. The only area that I don't use a cannula on almost exclusively is in the lips. And let's just move on and talk about the lips now. So we used to think that it was very safe, but in the last 6 months, when I have former students or colleagues tell me about their vascular occlusion episode, it's in the lips. And thinking about the structure, the vascularity of the lips, we do have peripheral circulation kind of coming from everywhere, but we also have some big vessels there. There was an Instagram post I saw last week of like a lower lip pulled out, and you could see the pulsating of the artery right there. It blew my mind. So amazing. Remembering that your patient's anatomy is very different, can be very different from person to person to person. So maybe somebody's had trauma in an area of their mouth, and now their vascularity is not as good as it used to be. They don't have that peripheral circulation, or maybe they just were born in a way that it just is different than everybody else. And you need to follow the same safety protocols. So going in with a needle, aspirating, going slowly, and injecting a small amount of your HA filler. What I have seen recently is a lot of people using the insulin syringes or their HA filler in the lips and thinking that this is so safe because it's a small amount. And granted, it is a small amount. If you're using a 30 unit insulin syringe, you're going to get aliquots in there for sure. But you have to think about that extrusion force again. So now we're pushing the HA filler through a 30 or 31 gauge needle, and that tiny barrel of the insulin syringe, you have to push pretty hard on the plunger. So there's a high extrusion force there. And we know that the harder you push, the faster the HA gel goes in there, and it can lead to a vascular occlusion episode like that, which is what's happened in 2 of the last episodes that I heard about, were both with insulin syringes. So I see that it's very trendy. I see a lot of people doing it on Instagram. It's not like bad, but you have to remember, you still have to think about safety and what is happening here. Sometimes the classic ways are the best, just a 27 gauge 1/4 inch needle, laying the product down linear, superficially typically, and aspirating and just watching what's happening. So what was happening when my colleagues had experienced this, it was an immediate bruise. It was something that they said just didn't look right. And that is what I hear time and time again when these vascular occlusion episodes happen. And then the good thing is that they treated it, even though they weren't sure, they treated it just like it was a vascular occlusion, totally mitigating any adverse events, adverse results, and patients were fine. So think about that. Think about, you know, all the lips are really your chance to be super creative in a way that is uniquely yours. You don't have to pay somebody else to learn their lip method. If you feel like you want to break out a cannula or a 27 gauge 1/4 inch needle, or, you know, the insulin syringe, do you, but always have that element of safety in mind. I am starting to rethink my needle only in the lips, and will likely start doing more cannulas in that area. It's just, the goal is to provide the utmost safety, and the reports that I've heard are concerning enough to make me reconsider my technique in that area. So I encourage you to do that as well. Moving on, let's talk about the marionette area. So down here is a very common place that people will come to us. We lose our density here. We lose our fat pads. We also lose our ligament structures in this region. What's really a cool way to go here is to use your cannula and come from this angle and subsize first. So we have all this connective tissue in there that can pull the skin down and make this area look worse. And so if you go in there with your cannula before you actually lay product down, then you can create a nice lift in there. And it does not feel good, especially with the 22 gauge cannula. So it feels better if you can just put down just a tiny bit of that HA filler, because there's lidocaine in it, and so it makes it more comfortable for your patient. But you just kind of go in there and just kind of do some fanning, subsize that tissue first before you lay down the filler. And doing the same way, you're going slow, you're using small amounts, all those safety things that we talk about. Really good way to do the marionettes, but also remembering that doing cheeks is going to affect this region. So another thing that we have alternatives to HA filler. We now have the polydaxanone threads. So all these areas we talked about, the lift threads can pull these areas. So staying away from filler completely and just going with PDO threads, super, super safe. I have been training in some offices recently on PDO threads, and that's all they do. They're not doing filler at all. They're just doing PDO threads because they realize the risk of dermal filler and the benefit of PDO threads and the element of safety that PDO threads provide. So PDO threads, another area that we can use those are in one of our no-fly zones. So in our glabella area, we can, those 2 deep furrows or 3 or 1, if you put a PDO thread there, you're not going to run the risk of a vascular occlusion from that. You're not going to have edema that can then compress the vessel. You're not going to have a direct injection that causes pressure and backflow into the retinal artery, therefore causing blindness. They're just very, very safe. They do require repeated treatments in that area to stimulate collagen development and fill in that line. The other options in that area are a finely whipped filler placed very superficially in that region. I always tell my patients to keep up with their neuromodulator and to use some exfoliative type of things there. So addressing the outward appearance of their skin there. So using a retin-based product there, doing microneedling there, in addition to the PDO threads, all those things. If that's really the bane of their existence, their #1 priority, you can definitely help with that without putting an HA filler in there. This is a no-fly zone. The other no-fly zone is here, liquid rhinoplasty. Just don't do it. The last thing I can think of, like, what's worse than causing a blindness is causing a necrotic nose. Like, I can't even believe I'm seeing people still doing this procedure on Instagram. And the one that I saw most recently was by a plastic surgeon, and I literally like cringed in my seat, and it just blew me away. No, it's a no-fly zone for so many reasons, but you have so much vascular structures up there. And what this plastic surgeon was doing was showing this procedure on this patient, and she even said that it was not her first time having the procedure done, which is one of the reasons another reason not to do it, because it's not permanent. So if somebody does not like their nose, let me go see a plastic surgeon and have it permanently addressed, rather than keep running the risk every 6 to 9 months and getting repetitive HA filler there. And then this plastic surgeon went on to promote her training of this. So said, you know, this is not an easy procedure. If you want training, come see me. Which I had a hard time watching that. It all goes back to patient safety. Most of us, most of you, from who I saw sign up for this webinar, are injectors in small offices. You're not plastic surgeons. You don't have an OR ready to go. We initially reached out to one of our colleagues who is a plastic surgeon and asked about this procedure. This was a couple years ago when it was just starting to gain some popularity, and he just said, no, just don't do it. Just don't do it. So no-fly zone, liquid rhinoplasty. So we've talked about some of the safety measures that we have in place, and hopefully that was really thorough for you, and hopefully that was also very hopefully that was a reminder. Hopefully you guys already knew most of that stuff. So what does a vascular occlusion look like? Let's touch on that a little bit. I did already somewhat, but vascular occlusion typically is going to be a dusky or a blanched out appearance. So that's one reason not to use epinephrine anywhere in mid-face. Anywhere you're doing dermal filler, don't use a lido with epi, because you won't recognize a blanching based upon a vascular occlusion episode should it occur. The dusky appearance, it looks like a bruise, like a weird bruise. It just like suddenly pops up. Your patient may or may not experience a sudden severe pain. A lot of our patients our topical anesthetic is very good. Our lido blocks that we'll do an oral lido block, those are also very good. So they may or may not experience a sudden pain. And I'm going to reference Julie Bass Kaplan again, go back and read her story, her symptoms that she had initially. And those are very classic. So that's an immediate vascular occlusion. The alternative is a vascular occlusion episode that happens secondary to the treatment and usually presents the next day. And the patient will have had so much edema in that area, slow growing edema in that area, that it compresses the vessel. So your patient will typically call and say, oh my gosh, my face hurts so bad, like just a gentle touch. And I touch this area because this is where I've heard about it happening, have heard firsthand reports of it being in the NLF area. So just a light touch onto the patient's skin in that area causes a 10 out of 10 reaction. So the other thing that they will present with is already some little vesicles developing there from the tissue hypoxia. And those look a lot like vesicles, like a herpetic wound, but they can also look a lot like an infection. So it's important to realize, oh, I put filler in there, so it's likely a vascular occlusion, and I follow aseptic protocol. So, you know, the chances of them getting an infection in that area and it manifesting that quickly are pretty low. It's more likely a secondary vascular occlusion. You're going to treat it in the same way. You're going to immediately dissolve that area with your Hyalinics and move on down the treatment protocol. But what's more important is to mitigate that and to prevent that from happening in the first place. So ice, we always want to give your patients ice. I had a patient who we were doing her lips, and I handed her an ice pack, and she said, no, I like the swelling. And I said, no, we don't like the swelling, and this is why. And once I explained to her why I didn't want her to have an excessive amount of swelling, she totally understood. She took the ice pack. The other thing you can do is pre-treat and have the patient take after the treatment with our histamine blocker and our antihistamine. So we used to just say Zantac, Zyrtec because it was easy for the patient to remember, but Zantac has been pulled from the market. So we do Pepcid and Zyrtec. So an antihistamine that is non-drowsy, and then a histamine blocker. Pepcid is actually the best. So that's what we go with. And pre-treating them and then having them take those 2 medications every day for the next 3 to 5 days is going to help that edema resolve much quicker. And it will likely cause them to have less edema acutely. And at night, even, I will have patients to take a Benadryl. So hit hard at nighttime with like a Benadryl that's going to really calm down the swelling that they might have from their dermal filler. And that way, the chances of them having a vascular occlusion episode secondary to the injection will be much less likely to occur. So those are some little pearls of wisdom that we've gained over the years. Just as a wrap up, again, if you don't have a protocol, I will send one to you, and I encourage you to make it your own. There's some things you may want to throw out, some things you need to keep, and others that you may have questions about, but I also have a really good research article to send as well that this was all based upon. So in wrap up, remembering your safety things, and when I'm teaching this in class, when I'm doing the dermal filler day, I say that it's like golf. There's so many things to remember. You're gonna aspirate. You're gonna use let's say you're gonna use a cannula. You're gonna aspirate a large bore cannula. You're gonna do periosteal boluses. You're gonna remember your no-fly zones. Just don't do it. You're just walking on glass, treating those areas with HA filler. You're gonna go slow. You're going to be very conservative. You're going to lay your filler down in a retrograde motion. All these things all together are going to make you the safest possible injector. And my hope is that none of you ever have a vascular occlusion episode, and it's not because you're lucky, it's because you're safe. And safe means you're good and you're great and you're giving your patient really, really good results, but you're also ensuring their safety. So I hope you guys got some information and some, sorry about that, I don't know where my video just went, that this was helpful to you. There it is. And we've got time for questions if you guys want to discuss anything. So I have a question. What's your depth with the cannula on the NLF? That depends. If it's a more superficial line, then you can definitely go more superficially. You can also do like your normal depth that you would mid-dermis with the cannula and see the tissue rise. So a layering. So do the mid depth to get kind of a good structure, and then if it's more superficial, then follow with that. Or using your HA, your finely whipped HA, and just using a needle at that point, just to do this very superficial line. But again, this is an area that I often will just do a polydiaxanone thread and just do a PDO thread right there if it's superficial. If it's deep, you're gonna go at the same depth that you would as if you were using a needle. Great question. And then pre-treating with Decadron. No, I wouldn't pre-treat with something like Decadron. That's just getting into some people swell a lot, some people don't swell at all. And getting into a prescription medication region, I would be more concerned that they would have some sort of reaction to the Decadron. So I would just stick with the histamine blocker and the antihistamine. It works really, really well, and there's no adverse reactions to it. It's super benign, and your patient can get it over the counter. So I just wouldn't want to enter into territory where they might have a reaction from a prescription medication. You guys have any other questions? Anybody have any stories about episodes that they've had? And like I said, the ones that I've had recently from colleagues have been totally stopped by a quick administration of Hylenex and then watching that patient. So if you get in a situation where you have to do that, you're not sending your patient home. You're hitting them with a Hylenex, a high dose Hylenex, and then you're watching them, you're hanging out with them, they're staying in your office for at least 30 minutes because it may look like that area is reperfusing, but you may backtrack again. So always make sure and keep that patient in your office to watch them for a little bit. I'm cracking up because I had a colleague call and tell me about her patient that this had all happened to, and she put Hylenex in there, and I'm like, well, how does she look now? And like, it literally had just happened. She's like, well, I don't know, she left. Like, where'd she go? Get her back in the office. And she was like, well, she had to go to dinner. So she eventually got her back in the office, and she was totally fine. Let's see, what else? Anything? I hope that I will see some of you guys at my at the conferences that are coming up. Right? Yeah. So Gloria shared that she had her first occlusion since she was in class with us, and it was in the corner of the mouth. So this area is big for vascular occlusions because of the vascularity there. Our facial artery, it splits there, it comes this way and it goes this way. So this is a really common place to get a vascular occlusion. And she said it was mouth and the chin on the same side blanched immediately. So there's an immediate blanching. Great. And Gloria said, followed the protocol and everything was fine. Patients do very well. Yeah, cancel the rest of your afternoon. You just need to be very conservative and treat those patients like they get your attention for the rest of the afternoon. You want to just make sure that everything's cool. Awesome. Love it. All right, you guys, unless there's any other questions or discussion, I hope you learned something. Please give me feedback. I think you'll get like a survey at the end of this, perhaps, and would love to hear some feedback. And we'll be repeating this webinar again. I just got a question on Instagram about a video on how to give hyaluronics. And, you know, I'm not sure. I don't really have an answer to that. I hear it described many times, but from what I've heard and how people do it, maybe Gloria can also back me up on this. So you just, you know, you pull it up. Luckily, hyaluronics comes already mixed. You don't have to mix anything. You just pull it up. You can you can use an insulin syringe or your 27 gauge needle on a 1cc syringe, and you would get right in there and just like put it in or fan it around that area where you place where you had placed the HA filler. Does that sound right, Gloria? Is that the way you did it? And I will definitely send you the protocol. Send me, just send me an email if you guys want the protocol. Send me an email, and then I'll just, in a reply, I'll attach it and give it back to you. But I think that's a great idea to do a video on how to give the hyaluronics, and that's something that we can work on here. But you basically just want to get it in there as best you can. And yeah, I will send everybody, if you reach out to me, let's see. Yeah, so Gloria said she flooded the area, heat and gentle massage, took about 3 minutes for the blanching to resolve. So for reperfusion took about 3 minutes. Anytime you're using hyaluronics, using some massage with it, whether you're treating a vascular occlusion episode or you're, it was she used a 3cc syringe. You, if you're just treating a little bump or lump in someone's lip, you're going to want to massage that too. So when you use your hyaluronics, you want to definitely massage the area. And some warm compresses are nice too. Thank you, Charlene. Okay, if you want the protocol, email me first. So Wendy at pnwaestheticsacademy.com, and I will get it to you. Wendy at PNW Aesthetics. It's back there. AESTHETICS. Thanks, you guys, especially if you were first time with us. Thanks for coming, and please reach out to us if you need anything. Happy to help. And remember that we're all in this together. And the better we are individually, the better we are as a group. So we're very big on community over competition. So, and remembering that our first priority is always patient safety and doing no harm. We're healthcare providers. Wendy at pnwaestheticsacademy.com. Also, if you go onto our website, you can reach out there. There's a request more information page, and I get those emails, so you can send those to me with the request. All right, you guys, thank you so much, and I hope to see you on another webinar. We'll likely repeat this webinar next month, and so let your colleagues know if you found this helpful. We would love to have more people watch it. Thanks, everybody. Have a great day.